Good afternoon, respected judges and audience. I'm Dr. Shipra Dobal, and I will be presenting my presentation entitled Multiplex PCR for detection of carbapenemase genes in carbapenem-resistant enterobacteriales causing urinary tract infections in a tertiary care hospital in North India. So, carbapenems were considered as one of the last line resorts for the treatment of multi-drug resistant organisms causing urinary tract infections. But the massive use of these drugs in communities as well as hospitals has led to a rise in carbapenem resistance. This increase in carbapenem resistance is becoming a problem because this has led to limited treatment choices which are available now. It has led to increased morbidity and increased mortality in patients associated with UTI. The reason for this carbapenem resistance, the most common mechanism which is suggested is the production of a carbapenemase enzyme. And the carbapenemase enzyme production is causing more of a problem because it is the genes coding for this enzyme are present on mobile genetic elements. So the organisms which are producing this enzyme, there's a rapid spread in the hospitals as well as in the community of this organism. So carbapenemase producing organisms are causing much more of a problem than the non-carbapenemase producing organisms which are showing carbapenem resistance. So detection of this carbapenemase enzyme is recommended by the Clinical Laboratory Standards Institute for surveillance purposes only. But the identification of these are becoming important because now with the limited drugs available, we have new drugs which are coming in the market and their action actually depends on the carbapenemase. For example, ceftazidime avibactam is a drug which is not useful on metallo-beta-lactamase producing bacteria. So whenever we're using this drug, we have to make sure that the patient does not have MBL. Plus, if we're using in an MBL patient, we have to make sure we're using it with an astronam to make it efficacious. So the objectives of my study were to compare the demographic details of patients with carbapenem-resistant enterobacterial uropathogens and to identify the genes responsible for carbapenem resistance in these uropathogens. So it was a prospective observational study from January 2022 to Feb 2022. The inclusion criteria was urine samples with a colony count of more than 10 to the power of 3. These included catheter samples. Majority of the samples were catheter samples. Then uropathogens with pan-drug resistance, including resistance to carbapenems, any of the carbapenem, imipenem, meropenem, or ertapenem, and uropathogens showing carbapenemase production using modified carbapenem inactivation method, which is the gold standard method, which is being recommended by the CLSI. Exclusion criteria were samples which showed contamination, or if the colony count was less than 10 to the power of 3, or the uropathogens were negative for carbapenemase production. So the methodology was that the uropathogens were tested, like first we processed the sample, then once the isolate was confirmed to be enterobacterial, we performed antimicrobial susceptibility testing using Kirby-Bord disc diffusion method. And if the drug was found to be resistant to most of the antibiotics plus resistant to carbapenems, then we processed further. We then detected if it was producing any carbapenemase enzyme. For that, we used the modified carbapenem inactivation method recommended by the CLSI. Then if it was positive for both of these categories, then we proceeded with the multiplex PCR. We use the high pure bacterial genomic DNA extraction kit, followed by the high PCR carbapenemase multiplex high media PCR kit. So in this kit, there were 2 master mixes which focused on the various carbapenemases which are available. The data validation, this is an image of the positive control graphs that I obtained and the various genes and the dyes which were used in their detection, which were available in the kit. And the result interpretation, they only give that if the CT value is less than 40, then we called it positive. Then the enzyme was said as detected. Otherwise, it was not detected. So results, we received 67 enterobacterial isolates in this period, and 20 of these isolates were multi-drug resistant that fell into the category that we defined. These isolates had, as we can see, resistant to almost all of the drugs. They showed some susceptibility to amikacin, gentamicin, and some susceptibility to tetra and doxycycline. But most of the drugs which are used were all resistant. All fluoroquinolones were resistant, and aminoglycoside, some susceptibility was seen. Among the demographic details of these patients, it was seen that it was more common in males, and it was more in the age group of 40 to 60 years. This we thought was attributed because most of these patients were already in, because males are generally for complicated UTIs only they go, plus most of these patients were inpatients. So they had an indwelling catheter or other risk factors, which I've explained further. And admission-wise, 45% of these patients were OPD cases, 35% were from ICUs, and 20% were from wards. Risk factors, so we can see 60% of these cases were males. Then the other risk factors were indwelling urinary catheter was present in 40% of the cases. 35% of the cases had diabetes, 15% had a chronic underlying chronic kidney disease, and 15% had a obstructive uropathy like renal stones. Then all 20 uropathogens were positive for carbapenemase production that we tested using the modified carbapenem inactivation method. And then we proceeded with genotypic identification. This was the result when we proceeded with the genotypic identification using first master mix, which detected the metallo-beta-lactamases. So among them, we saw in 5 out of the 20 isolates, NDM was positive. In 12 out of the 20 isolates, we found co-carriage of NDM and KPC. And in 3 isolates, we found NDM, KPC, and IMP. And in the second master mix, which detected the oxacillinases, we found 12 of the 20 isolates had an OXA48 present. And OXA58, which is actually a gene responsible for resistance in Acinetobacter baumannii. It is not responsible for resistance in Enterobacteriaceae, but still it was detected in 3 of our isolates. So when we compared the results, when we combined the result of both the master mixes, we saw that BLA-NDM was the most commonest gene which was detected, followed by KPC and OXA48. OXA58 was detected in 3 out of the 20 pathogens. And we can see the maximum number of cases were the co-carriage of NDM, KPC, and OXA48. So coming to the discussion, the common organisms that we had was E. coli, which was 80% of the isolates, followed by Klebsiella pneumoniae, which was accordance in studies by Mana et al. And Veera Raghavan et al. Then similar to our studies, various studies have also reported that carbapenem resistant isolates, which are usually resistant to most of the drugs, had some susceptibility of 10 to 30% to amikacin and tetracycline. But if these are effective in the patients, that is not known. Then carbapenem resistant Enterobacteriaceae frequency was the highest in males of 40 to 60 years of age. Carlson et al. Said that patients with medical devices undergoing invasive procedures or admitted to intensive care units have a high risk of developing carbapenem resistance. In our study also, out of the 20 patients, 40% had an indwelling catheter. And among the comorbidities, 45% of the cases had an underlying diabetes. And in the PCR testing, it was seen that in the Western countries, OXA48 and KPCs were common. But in our country, NDM was the commonest, followed by KPCA and OXA48. Conclusion, the most common gene detected was NDM. Majority of the carbapenem resistant isolates also showed co-carriage of multiple genes. OXA58 was detected in an Enterobacteriales isolate. And with this rapid rise in carbapenemases, the treatment options are becoming limited day by day. And CDC recommends active surveillance and following infection control practices to control these carbapenemase spread in various hospitals. Thank you.